Readmission is defined as patients' admission to a hospital within 30 days of being discharged from the same or another hospital. Centers for Medicare and Medicaid has started penalizing hospitals with high 30-day readmission rates for heart attack, heart failure, and pneumonia patients by reducing reimbursements because high readmission may indicate inadequate treatment received by a patient from the previous hospital. Up until now, two-thirds of hospitals have been subjected to a 1% reduction in Medicare reimbursements since 2013. This penalty rate will increase to 2% in 2014 and to 3% in 2015. In this research, we question the Centers for Medicare and Medicaid Services readmission assessment for ignoring the impact of non-clinical factors on patients' readmission risk. Mainly, we are interested in two non-clinical factors that may affect the readmission process. These are patient insurance coverage and patient health status outside the hospital, which is not observable to healthcare providers and researchers. First, insurance coverage may impact a patient's decision to be readmitted. We argue that lower patient financial liability increases the readmission propensity of patients as they will be less reluctant to visit hospitals. And second, patient health status may depend on factors such as lifestyle choices, alcohol or drug abuse, lack of access to outpatient facilities, and social support from family and friends. We argue that patients with worsened health state outside the hospital will be more likely to require readmissions following a discharge. Overall, these two factors are neither controllable nor modifiable by hospitals. Basically, they are exogenous. To test our hypotheses, we utilized the Dallas-Fort Worth Hospital Council Foundation inpatient dataset of congestive heart failure patient visits. In our econometric approach, we conduct a quasi-experiment to test the effect of changes in insurance policy on patient readmission risk and also apply hidden Markov model since the patient health status is not observable to the provider. Our results indicate that once privately insured patients switch to Medicare, readmission risk increases by 79%, and once self-pay patients switch to Medicare, readmission risk increases by 97%. In addition, we find that there are substantial differences in readmission rates among patients in different health states. For instance, less healthy patients have significantly higher readmission rates compared to the healthier patients. Our findings suggest that policymakers should consider non-clinical factors that impact patients' readmission propensity along with clinical factors that can be under their control.